about complications and evolution of complications over time. Luckily, how many people in the room here are adult deformity surgeons? So congratulations, you have chosen a complicated field and the most complex of that field and the one with the most complications. So that should make you feel good or depressed. I'm not sure which one. There we go. And there we go. Here are my disclosures. Nothing for this talk. So we know that deformity surgery has high risks. We know that the complications are frequent and varied. Steve Glassman looked at this in 2007, found complication rates of nearly 40%. And Justin Smith looked at this again in 2016 and found that, guess what? Our complication rate went higher. It was 70%. And so, are we getting better with these things over time? Steve Glassman looked at major and minor complications and tried to understand whether or not those affected our patients in the long run. He wasn't really able to tie that together necessarily, but still we know that we want to decrease complications for all the reasons that we just talked about in terms of decreasing cost and increasing our outcomes. The one hard part, Mike talked about an airplane crashing. I don't have any pictures of airplane crashing or the Challenger disasters. In some ways, those complications are easy to identify, because something happened right then. Some of the complications that we're discussing don't happen in the operating room. And in fact, may not happen for years afterwards, but still could be solved or addressed at that time. And so I want to first look and think about this survival curve of complications and when complications occur. This is a study that we did through the ISSG, and we looked at nearly 1,000 patients with 2-year follow-up. And you can see a lot of the complications happen in that early perioperative period, but the complications continue to occur over time and continue to occur for our patients and continue to impact them and impact the quality and cost of the care that we do. If we look at the complications in terms of major, minor reoperations, you can see that they decrease over time but continue to happen at an appreciable rate. If we look at specific types, we look at medical complications, those tend to happen early, but you can see that there continues to see neurologic and pulmonary complications that continue to occur over time up to 5 years out. Medical complications that are associated with our surgery happen even more frequently and continue to happen over time. Radiographic imbalance, wound complications, neurologic complications, implant failures continue to occur throughout the life of our patients. And this is why it's so critical to follow our patients over time to really understand what that complication and when it occurs. We've changed a lot in our practices. And so luckily, we're adaptable. And when we see a complication, when we see something happen to our patients, we react to it. And I think we react to it fairly thoughtfully. And so let's look at some of the advancements that we've done. So rod fracture rate, we saw that when we used 2 rod fractures and we did 3 column osteotomies, we started moving to accessory rods. How many people here use accessory rods for osteotomies, for pedicle subtraction osteotomies or VCRs? And the answer is that really has become essentially the standard of care. If we look, we can look at multi-rod constructs. These are a couple articles showing that we had similar rates of rod-related complications, and that the rod fracture rate actually decreased was 50% when we decreased with the increase of the number of rods. We looked at standard rods had a higher frequency of rod fracture, pseudoarthrosis, and reoperation, and when we used nested rods, we decreased those rates, making a difference potentially for our patients down the road. What about radiographic problems? PJK, PJF, a significant problem. Certainly we have management strategies, maybe not solutions. We've started thinking about tethering at the UIV +1 or +2. I think Frank Schwab was talking about doing tethering at UIV +5 and 6. And so talking about multi-levels, I don't know where that's going to end necessarily. We look at FEA analysis, we can see that the tethering makes a difference. If we think about not just tethering at that junction, but getting the alignment right, then maybe we can have lower junctional failure. And this one talks about that improved alignment targets decreases our rate of complications with rod failure and PJK. And so maybe it's not just about what we do at that upper level, but maybe what we're doing before the surgery and planning for that operation. Infections, Mike talked about infections and how devastating that is for our patients immediately and down the road. We've certainly changed the way we do this. When I first started my practice, we looked at, blood loss. So TXA first we're going to talk about blood loss. Blood loss used to be is a big issue in our operating rooms. Obviously, we're doing these large surgeries. TXA has now become the standard of care in the operating room. We look at high-dose TXA. It has shown a huge difference in decreasing the rate of transfusion and really become now the standard for how we treat our patients. And here we go, meta-analysis, all showing an increased difference, all showing increased decreased rates of blood loss when we use these different dosing regimens. And I think we could probably argue about which regimen is best. Infections, Mike talked about infections. And so vancomycin powder now has become the standard of care. We're using vancomycin powder in large meta-analysis looking at this, that vancomycin decreases the rate of SSIs and decreases the rate of gram-positives. But what is the cost? And are we potentially pushing some of these infections to gram-negatives? And so here they saw a decreased rate of gram-positive, but an increased rate of gram-negative infections in those infections that occurred. And then again, another paper demonstrating nicely that Staph aureus and Staph epidermidis decreased rate of infections with vancomycin. Well, with all these advances, how has this changed our complication profile over time? And so if we looked at our 10-year enrollment in the ISSG and to try to see what happened to our patients as we've continued to operate. And you saw Mike showed that picture of the dramatic increase in rate of surgery. And who are we operating on? The answer is that we're operating on older patients, we're operating on sicker patients, and we're operating on patients with a higher BMI. And potentially that's because we've gotten better at what we do, or is that we're taking larger risks with the patients that we have. If we look at what happens over time, so you can see here's the busy slide looking at the fusion length, supplemental rods, invasiveness of 3-column osteotomies. We're using more interbody fusions as we go on. We're doing more ACRs and less 3-column osteotomies. I suspect Larry's going to talk about that and decreasing neurologic complications. We're doing shorter fusions, and we're using more supplemental rods and more BMP to get that fusion early on so the patient has a long and durable result. In terms of major complications, we look at neurologic complications. You can see that actually is increasing over time. Operative complications is decreasing. Implant failure, malposition, decreasing. Implant failures also decreasing. But a dramatic change in how we're doing things and where are we shifting those complications. If we look at PJK over time, very sobering slide. The line is essentially flat. So we have the same PJK rate now that we did when we first started in 2011. So pretty amazing and substantial numbers, right? Substantial numbers, substantial impact. So with all this, complications are frequent. We've made some real progress in how we care for our patients in terms of infections and blood loss. We've used vancomycin and TXA. Those are really standards of care these days. Implant fracture and pseudoarthrosis, we're starting increasing the number of rods we use. We're starting to think about BMP, but are we just kicking that can down the road? Are those rod fractures now not going to occur at 2 years or 5 years, but maybe we're going to see rod fracture rates at 10 years and 12 years. And so we potentially are kicking that can down the road. And really the most sobering thing is PJK, we really haven't made much of a difference. So despite the tethering, despite the alignment parameters, despite all the things that we talk about in all these meetings, it turns out, at least in this the ISSG database, that the PJK rate is essentially maintaining the same rate. So with that, thank you.
Good evening.